So now we move to the adjuvant setting in HER2 positive patients, and this will be addressed by Dr. Krop from Harvard in Boston. Thank you.
Thank you. Good afternoon. I'd like to thank the organizers for inviting me back to this great meeting. I'm particularly pleased that I get to talk about early stage HER2 positive disease because, as you've heard now in several lectures, that this is an area in which the paradigm for therapy is changing currently. And I updated my title to reflect the fact that we're finally at a point where we have a functional dynamic biomarker that we can use to stratify our patients and improve outcomes and reduce toxicities. So these are my disclosures. So we know that outcomes for HER2 positive disease are already quite favorable. This is probably the latest large data set from the Affinity trial showing that even in this predominantly node positive population, the 4-year invasive disease-free survival is over 90%, even in the control arm. And then if you look at small node negative cancers, the invasive disease-free survival is over 98%. So clearly these patients are already doing well. But this means that we have the opportunity, and I would say also the responsibility, to use risk stratification strategies to minimize overtreatment and undertreatment, and also to explore de-escalation strategies to potentially further reduce the toxicities of our treatment. Now, we already have a number of risk stratification markers available to us, from the old school anatomic features of size and lymph node status and hormone receptor status to the more sophisticated intrinsic subtypes and other gene expression profiles, immune markers, and somatic mutations. And these were all discussed very well by Dr. Pratt yesterday, so I won't review them again. But of course, now we have a marker that we already knew about for some time that we're now learning how to actually utilize in practice. And so this is pathologic complete response after neoadjuvant therapy. Nadia did a very nice job showing the wealth of data on this biomarker. These are the cortisar data, which again shows substantially improved outcomes in patients who have a PCR, showed in red, compared to those who don't, shown in blue, with a greater effect seen in hormone receptor negative HER2 positive cancers. This was also validated in more recent data from the I-SPY trial, again showing a large improvement in outcome in those patients who had past CRs. And then recently, we also showed in the CLGB 40601 neoadjuvant trial that was led by Lisa Carey that if you look at specific intrinsic subtypes, that it's the HER2-enriched population that seems to have the biggest differential in terms of outcomes with or without a pathologic complete response. So I think the data are pretty clear that lack of past CR is associated with inferior outcome. But of course, the big question is, can we do anything about that? And of course, now finally, we have the data from Catherine, which helps to answer that question. And you've now heard about Catherine trial several times the last few days, but I thought because this is what I think clearly a practice-changing trial, it's worth talking a little bit about more in depth. So this is a study that basically, as Nadia mentioned, was a fairly pragmatic design. It allowed patients with centrally confirmed HER2 positive disease who had received virtually any of the standard chemotherapy trastuzumab-based neoadjuvant regimens. It just had to have at least 6 cycles. And the primary eligibility criterion was that had to have some invasive residual disease after completing neoadjuvant therapy. And these 1,400 plus patients who had residual cancer were randomized to either a control arm of 14 cycles of trastuzumab or 14 cycles of T-DM1 at the standard dose that we use in the metastatic setting. These were the characteristics of the population. They were enriched for hormone receptor positive patients as expected because, as Nadia pointed out, those patients have lower rates of past CR. And interestingly, patients who had dual HER2 therapy as part of their neoadjuvant treatment were allowed on the trial. About 20% of the patients did have dual therapy, virtually all of which was pertuzumab based. And this is the primary outcome of the study, invasive disease-free survival, and you can see there was clear large magnitude of benefit with the switch from trastuzumab to TDM1 shown in blue. The hazard rate was 0.5, hazard ratio was 0.5, and this translated to a large absolute magnitude of benefit of about 11%. Similar improvements were seen in distant recurrence, and overall survival, which was immature, still showed a trend in the right direction for TDM1. Looking at the forest plot, you can see that the benefits of TDM1 were seen fairly uniformly across all of the typical subgroups. Of interest, those 20% of patients who received neoadjuvant pertuzumab also received about the same benefit as those who had trastuzumab-based therapy alone. And the benefit was similar whether you were hormone receptor positive or hormone receptor negative. All of the results were not quite as rosy, though. The node-positive patients who at residual surgery had node-positive disease still had an IDFS of 83%, so clearly there's still a ways to go. This is not a cure-all for all patients. And similarly, looking at the first IDFS event, the rate of CNS metastases as first event was small, but not at all improved by the switch to TDM1. TDM1 was well tolerated. Only about 18% of patients were not able to complete the full 14 cycles. The reasons for discontinuation were the typical things seen with TDM1, typically laboratory abnormalities such as thrombocytopenia and liver function test abnormalities. So what are the implications of the Kaplan trial? So certainly it provides proof of concept that the effect of a neoadjuvant therapy regimen can identify patients who can benefit from a change in therapy, that specifically 14 cycles of TDM1 should be considered a new standard of care for patients with residual disease after neoadjuvant trastuzumab-based treatment, and suggests that it is advantageous to treat most patients with moderate or high-risk disease, and we are, I think, all collectively defining that as stage 2 or higher, with neoadjuvant therapy so that we can identify those patients with residual cancer who may benefit from adjuvant TDM1. So other implications, well, as I mentioned, CNS recurrence remains a relatively infrequent, but when it happens, devastating event, and this was not at all impacted by TDM1, so we still need to do better here, and we need to explore new CNS targeted agents to try to do better in this area. And as you've already heard from Eric and Martine earlier, as we switch to a more uniform utilization of neoadjuvant therapy, we're going to have to ensure that multidisciplinary care is widely available so that we can use neoadjuvant therapy optimally. So there are a number of questions about how we can implement the Kaplan results. First off, do we know that adjuvant TDM1 is superior to adjuvant trastuzumab and pertuzumab, which is arguably the standard of care for higher risk patients? Well, of course, there are no data comparing adjuvant TDM1 to adjuvant trastuzumab and pertuzumab. But I would argue that given the large magnitude of benefit seen in the Kaplan trial with a hazard ratio of 0.5, compared to the relatively small benefit of the addition of pertuzumab to trastuzumab in affinity with a hazard ratio of 0.8, again, I am inappropriately, I'm sure, using a cross-trial comparison, it would seem unlikely, at least to me, that TDM1 would be inferior to trastuzumab and pertuzumab, particularly in patients who failed to achieve a pass CR with a pertuzumab-based neoadjuvant regimen, which is going to be the most common population. Another question is, should TDM1 be used in patients with any amount of residual disease or only in patients with substantial invasive cancer at time of definitive surgery? And here again, turning to the forest plots, you can see that the benefit of TDM1 compared to trastuzumab was seen across all of the different subgroups of a residual invasive cancer by tumor size and by lymph node status. And this wasn't just by hazard ratio. You can see, well, you probably can't see, but if you look at the small print, the actual absolute improvement in IDFS was substantial across all of these different subgroups. So I do think we should be considering adjuvant TDM1 in virtually all patients who have residual invasive cancer. Are there any biomarkers that predict patients who would do better with an alternative therapy, such as trastuzumab and pertuzumab? Here, unfortunately, until we have biomarker data from Catherine as well as from Affinity, we really can't answer this question. Hopefully, once we do have these data, we'll be able to potentially identify patients who may specifically benefit from one or the other treatment. And lastly, is there a role for neratinib, the irreversible tyrosine kinase inhibitor, in patients who receive adjuvant TDM1 after neoadjuvant therapy? So as there are no available data on adjuvant neratinib after TDM1, or even after pertuzumab for that matter, it's difficult to definitively recommend neratinib in such patients. However, I do think it's worth considering neratinib in very high-risk hormone receptor positive patients after neoadjuvant therapy. Specifically, when I say high risk, I'm thinking of patients who actually progress during neoadjuvant HER2 therapy, those patients with inflammatory HER2 positive breast cancers, and those patients with many involved lymph nodes at time of definitive surgery. So I just want to speculate, mainly just because it's fun, on why the benefit of TDM1 is so large in the Catherine trial. Well, I think one thing, as we've kind of alluded to now, we've selected for a patient population who is resistant, at least to some extent, to trastuzumab-based therapy by using post-neoadjuvant patients. And we already know in the metastatic setting that TDM1 is quite active in patients who have refractory disease to trastuzumab-based treatment. We also know that imtansine, or DM1, the payload of TDM1, is much more potent, at least on a molecular basis, than standard conventional adjuvant chemotherapy agents such as paclitaxel. But I personally think that perhaps the biggest reason why the benefit of Catherine was as large as we saw was that TDM1 has a relative lack of cumulative toxicity, and that allows exposure of essentially a cytotoxic agent for 9 months more than we can do with conventional chemotherapy. And perhaps this very long exposure to a cytotoxic agent is enough to eradicate micrometastatic disease that otherwise would have the potential for recurrence. So we've talked about what to do with patients who fail to have a pathologic complete response. What about optimal therapy for those who do have a PCR? So in my opinion, the patients who achieve a PCR, the available data suggests we should continue the dual antibody blockade, if that's what they received in the neoadjuvant setting, to complete 1 year of therapy. The reasons I suggest that are because the Affinity data, which are the major definitive trial showing a long-term benefit to the addition of pertuzumab to trastuzumab-based therapy, did use 1 year. And those patients who have a past CR to a trastuzumab-pertuzumab regimen clearly have cancers that are sensitive to this dual blockade approach. And we only have very limited data on long-term outcomes with patients who have a shorter duration of HP, shorter than 1 year. I did note that Nadia suggested that using the dual blockade as opposed to trastuzumab alone should be based on the initial pathology guidelines, and I think that that's perfectly reasonable as well. So I think there may be some differences in that approach. So lastly, can we utilize neoadjuvant therapy to de-escalate treatment? Just as the data are very clear that lack of past CR is associated with inferior outcome, as I've shown you, data are also clear that achieving a past CR is associated with a favorable outcome. And so can we leverage this favorable endpoint to reduce the intensity of neoadjuvant therapy? Nadia and Eric already showed one of the trials that's being designed to try to address this question, the Compas trial in the United States, which will treat patients with a relatively low intensity regimen of paclitaxel HP for 4 cycles, followed by surgery. And those patients who achieve a pass-CR with this regimen will just receive the dual biologics alone. And the trial is designed to show that that regimen is associated with a very favorable outcome without any additional treatment. So because I do think this is a change in the paradigm of how we treat HER2-positive breast cancer, I think it's worth looking a little bit more in depth at what we hope to achieve by going in this direction. And I'm using some slides I've adapted from Hal Burstein to try to clarify this. So this is a model Kaplan Meier curve for what you'd expect for patients when we treat with HER2-directed therapy in the adjuvant setting. So obviously some patients recur, some people don't. But if we split that group up, by treating them in the neoadjuvant setting with the same regimen, we can identify patients with a PCR who do better and patients who fail to achieve a PCR who do worse. With Catherine, we now realize that we can treat that latter group with an additional treatment and improve their outcomes, and this leads to an overall improvement in outcome for the entire population, as shown in pink. So I think that that's been made pretty clear. But there's another aspect of this approach that I think is also worth discussing and also is potentially beneficial. So let's switch endpoints to toxicity. Now, the old school approach would be that if we have a new drug that we think can improve outcomes in the adjuvant setting, we would add it to everybody, and that might lead to an improvement in benefit or outcome, but it also certainly will lead to an increase in toxicity. And that increase is substantial because we're treating all the patients, as shown in pink. But let's say we use this new approach of a neoadjuvant followed by adjuvant approach. Now the patients who achieve a pass-CR, as shown in blue, don't need to receive the additional therapy, so their toxicity does not go up, and we only treat the patients who fail to achieve a pass-CR. So the overall toxicity for the population is decreased. Now, if we further evolve to a de-escalation approach, now we're only treating the patients with the additional treatment who fail to achieve a pass-CR in green, and we actually can decrease the toxicity of those patients who achieve a pass-CR with a lesser regimen. So again, this leads to a further decrease in toxicity, and at the same time, overall outcomes improve. So this is really the best of both worlds. We're improving outcomes and decreasing toxicity. And so I do think there really is a lot to be said for this approach, and I'm sure that this is going to be further developed over time. So just at the end, talking about the node-negative small cancers, just to review, we know these cancers have a higher risk of recurrence without treatment compared to HER2-negative cancers, and that led to Sarah Tolaney and Eric Weiner's APT trial, which treated these patients with essentially mostly stage 1 cancers to a year of trastuzumab with 12 weeks of paclitaxel. And as you've seen now in multiple presentations, this was associated with a very good 3-year DFS of almost 99%. Sarah presented long-term data at 7 years, showing that disease-free survival still remained quite good at 93.3%. There was a numeric difference in the ER-positive populations with slightly better DFS compared to the hormone receptor-negative HER2-positive cancers. But I would point out, as Nadia mentioned, the overall number of distant recurrences was 4 out of a total of more than 400 patients, so less than 1% distant recurrence. And in fact, of those 4 distant recurrence, 3 of them were estrogen receptor positive. So I really don't think there's any significant difference in the effectiveness of this regimen, or certainly the outcomes of this regimen for hormone receptor positive versus hormone receptor negative HER2 positive cancers. And that's reflected the fact that these events are very rarely distant recurrence is reflected in the recurrence-free interval, which focuses mainly on the drugs, on the events that systemic therapy can address. And you can see there that even at 7 years, the recurrence-free interval is over 97%. So I certainly think that we've confirmed that the TH regimen is associated with excellent long-term outcomes and remains the standard of care for most patients with stage 1 HER2-positive cancers. That does not mean that all stage 1 cancers need any chemotherapy or trastuzumab, and particularly T1A and 0 cancers at our institution, we usually do not use chemotherapy or trastuzumab. We are following up the APT results with a second trial, the ATTEMPT study, which is actually looking predominantly at TDM1 in this population, where we hope to be able to show that a regimen completely free of conventional chemotherapy is still associated with favorable outcomes. So putting all of this together, my proposed treatment pathway, which fortunately jives very well with Nadia's, and also I was pleased to see parallels the regimen proposed by Dr. Picard on Wednesday, where patients with clinical stage 2 and 3 disease are first treated with a standard neoadjuvant regimen, such as the ones discussed by Nadia. They then go to definitive surgery. If they have a past CR, they complete their year of either dual or single biologics. If they have residual cancer, they get TDM1 for 14 cycles or be considered for a clinical trial. For those patients who have clinical stage 1 disease, it makes sense to first go to definitive surgery. If they're confirmed to have stage 1 cancer, then the APT regimen of TH is the most appropriate option. If they are found to have occult lymph node positive disease, then a standard adjuvant regimen can be employed. So just to summarize, the neoadjuvant therapy for HER2 positive cancers provides clinically relevant risk stratification and facilitates tailoring of a therapy and should become the standard of care for stage 2 and 3 HER2 positive cancers. Adjuvant TDM1 in such patients with residual cancer is associated with a large magnitude of benefit and manageable toxicity, and also should be considered standard of care. There's now the opportunity for more precise tailoring of therapy using this neoadjuvant-adjuvant paradigm, and we hope to eventually de-escalate therapy further in those patients who have very sensitive cancers and potentially still need to escalate therapy in those who do not. And lastly, in patients with stage 1 cancers, the TH regimen is associated with excellent long-term outcome and remains the standard in that approach. So I will stop there. Thank you very much.